So, all right. Okay, so just I'm just trying to work on the slides, Varun.
We can see the slides, ma'am.
No, it's kind of not moving on.
प्योर गोल्ड का जो गोल्डन मिला था बहुत एक बार मेरी साइड पे रखेंगे मेरा है
Okay. All right. So, being a robotic surgeon and laparoscopic surgeon for many years now, I thought let me make you aware of the role of robotic surgery, especially with the benign gynecology. Now, please feel free to ask questions if you have any burning questions in between. Otherwise, after the end of the sessions, I'll be very happy to take your questions. We know that from many, many years, robotic surgery has a huge role in cancer surgeries. But now, with the advancement, it has taken up an excellent role with benign gynae, by which I mean doing the surgeries for the fibroids or endometriosis or dysfunctional uterine bleeding. Right. My special interest is benign gynae robotic surgery. I am also an advanced laparoscopic surgeon. I am a gynae oncology specialist. I'm also cervical cancer screening specialist and a colposcopy expert. Okay. Gosh. Right. Now, whatever surgeries we were able to do through laparoscopy, we can do through robotic surgery also. For example, whether it's myomectomy, which is removal of fibroid or removal of uterus or removal of ovarian cyst or endometriosis resection. So as we move on with the slides, I'll be able to show you some videos as well. Okay. Now, how have my last 27 years gone as a journey as a surgeon? So when I got myself trained, I started my training in 1992, but somewhere around 2000 when I started practicing as gynecologist, we were doing a lot of open surgeries. And then after 3, 4, 5 years, we started doing a lot of laparoscopic surgeries. And of course, for the last 3, 4 years, ever since I'm Da Vinci certified surgeon, I'm doing a lot of robotic surgeries. Okay. All right. Okay. I think I'm just trying to move on the slides so that I can show you the videos. Varun, can you hear me?
Yes, ma'am, I can hear you.
So first to show how the robotic system works. Now this is me sitting on a robot. This is a console. So robot usually has three parts. One is a console where the surgeon sits, and you can see this is like a driver's seat. This is a vision card where your team is looking while we are operating, and this is the patient with the robotic arms, as you can see now. And whatever I'm moving on the console, you can see here that the robotic arms are making the same movements. And here you can see the pedals and the hands. So that's how we work on robot. I describe it like, you are driving a car and you are the driver and the steering. And the clarity, as you can see, is excellent. And later on, you will see video of me doing hysterectomies and myomectomies, which means removal of fibroids. Okay. Right. So, right. Now, what is a robotic assisted surgery? Basically, as explained, we sit on a console. Here we have this camera, and this is a 3D camera, which means we have 360-degree rotation. And these are the different instruments, and this is how we translate the movements with the help of our fingers inside the patient. Now, when we are doing why robotic surgeries are better than laparoscopic surgery, this is a little video to show that how much can we see very clearly and what kind of specification it gives. So here, this is a little grape, and with the robotic surgery, the magnification is so good that you can even peel the grape while doing it. So this is precise, very, very precise, and especially in cases where there are a lot of adhesions, we are able to do it very precisely, and with very little chance of any complications. Robot being there is an AI mode as well, and which alerts you if anything is going wrong. So here you can see how beautifully we are able to peel the grape. Now, with robotic surgeries, you can do different kind of things. I can do hysterectomies on early endometrial cancers. Lymph node dissection is excellent. The stay usually even with these major surgeries is not more than 1 to 2 days. You can take out the omentum. You can do hysterectomy. You can remove the tubes, endometriosis resection, sacrocolpopexy, removal of ovaries, and cyst removal. These are the three main parts of robot. This is called as vision cart. This is a patient,
Mhm.
and these are the robotic arms. So usually there are 4 arms we can use or 3 arms, depending on the type of surgery. And third part is a surgeon console, where we would sit as a surgeon, and by sitting here, we are translating the movement to this robotic arms. So again, this is another picture showing how a robot looks. These are different part of robots. This is basically a very good camera where camera hopping can happen, which means if one camera is not functioning or the clarity is not there, you just press the button and then it takes over. There is a 3D vision which gives clarity and precision. And then these are different instruments. This is a vessel sealer, which is very excellent instrument because in some cases where you are expecting more bleeding, vessel sealer helps in sealing vessels very quickly, and there is hardly any need of blood transfusion in those cases. Now, why do we say that robotic surgery is better than laparoscopic surgery? Because patients experience less pain post-operatively, recovery is faster, it is much more safer, and blood loss certainly is less because of the excellent quality of the instruments that we are using. And therefore, there is a huge value of these kind of surgeries. The patient stay is reduced. Most of the 90% of patient, even after having the uterus removal and the fibroid, can go home in 1 day, as against laparoscopic surgery where minimum 2 to 3 days is needed. And if the same case is done as an open surgery, they may end up staying between 3 to 5 days. And because we have excellent precision, there is reduced rate of conversions, which means opening up the patient, which can sometimes happen in particularly with laparoscopic surgeries. The rate of, sorry, say that again. Okay.
It was excellent, ma'am.
Any questions? No. All right. There is reduced rate of complications, and of course, the readmission rate hence is less as well. Now, this is a video which I would like to show you on a patient who came from Singapore with multiple fibroids. And here you can clearly see that please notice in this video that how much blood loss is less. The instruments are precise. Here I'm cutting with the scissors, holding with the bipolar. So I'm trying to take out the fibroid. The white structure is the fibroid. This one. And you're just cutting the planes of the uterus. Now, she was a 37-year-old young girl who wanted to have children. So, of course, we want to preserve the uterus in this case. We want minimal bleeding. And when I'm reconstructing the uterus, we want construction to be excellent so that she is able to bear a 9-month pregnancy later on. So as you can see, there is very minimal bleeding, and I'm trying to take out the fibroid. which this particular fibroid was around 7 to 8 centimeter big. So again, with one arm, I can do the cutting, and the second arm equally, I am buzzing, which means I'm making sure that she's not bleeding. Okay. So these are smaller ones. Now, generally, it's very easy to lose the fibroids. The smaller ones can be taken out as we are moving along so that we don't lose it. And I normally hang the fibroid if there are multiple fibroids so that we don't lose them in between the intestine. And here I'm doing the suturing. Now, the suturing is very good with robotics because of the 3D vision, and you can give a very good tensile strength to the uterus. Okay, so that was robotic assisted myomectomy. Now, yeah, that's one of the testimonial from the patient, but we can pass that. Now, this is another video of robotic hysterectomy on a woman who was around 60-year-old, and she was having postmenopausal bleeding and her endometrium was thickened. So after discussion with her, we decided to go with hysterectomy. Here you can see the clarity. The tissues are so clear and the dissection is absolutely blood free. There is absolutely not even a single drop of bleeding, as you can see, because you can really dissect the plane without damaging other fatty tissue, which can normally bleed in laparoscopy. Hmm. And therefore, the time of operation with robotic surgery is even less than laparoscopic surgery because of the advantage, which means the patient are not under anesthesia for long, as you would expect comparatively in laparoscopic surgery. So here I'm doing robotic hysterectomy. This is a bipolar, this is a monopolar scissor. It works both for coagulation and cutting. And similarly, bipolar, I can use it as a grasper and also for coagulation. So you can see till now, very little bleeding has happened. So now once the bladder is dissected, here I'm cutting the uterus and we can see a cup which tells us that we are going in the right plane. So very minimal bleeding in robotic surgeries. And as I mentioned before, because of the clarity of vision, the risk of complication is almost very, very, very less as compared to laparoscopy. Okay, now you will see here again, suturing is very precise and easy in robotic surgery, and you can really tighten the vagina very nicely because it allows you to move your hand 360 degree. The camera you can move 360 degree and you're able to see, instead of moving the hands, you can move the camera. Okay, so this is the end of the procedure. And that's again one of the testimonial from a patient who was a 51-year-old. She had a large 10 centimeter uterine fibroid, and the patient was denied any laparoscopic surgery. And then after moving around for 2-3 months in different centers, I told her if she goes for robotic surgery, then I am very much confident that I won't have to open her. But with laparoscopic surgery, this kind of big fibroids or uterus, sometimes you have to tell the patients 5% risk of conversion to open surgery. But with robotic hysterectomy, I was absolutely sure that I wouldn't need to, open her up. So we went ahead and did her robotic surgery, and she was discharged after 1 day, and there was no need for blood transfusion as well. So yeah. And then there was another case of a 76-year-old female who was diagnosed with early endometrial cancer. And she was suffering from a lung condition called as sarcoidosis. So basically, her morbidity would have been higher. Under any circumstances, we didn't want to do an open surgery on her. And equally, doing a laparoscopic surgery, which would take longer time than robotic, especially with a compromised lung, was a challenge. So after discussion, we went for the robotic hysterectomy on her. And again, she didn't even need to go to ICU. There was no blood transfusion needed. And she went home after 2 days. So, so yeah, that's how the robotic surgeries have edge over laparoscopic surgery. And I'm now free to questions. Please feel free to ask.
Hi everyone. Please feel free to ask your questions. Dr. Deepika, one question is very obvious. Ma'am,
Yes,
your video is your video is not on.
let
Uh,
me just see. Wait a minute. Just give me 1 minute. Hmm. Wait a minute. Just give me 1 minute.
okay. So, ma'am, I have
Yes,
two
tell me.
questions, which are practical and related to logistics also. The first is going for robotic surgery,
Mm-hmm.
like as a guess, how much is the cost implication compared to laparoscopic or open surgery?
Yes, so yes, robotic surgery is little expensive than laparoscopic surgery. I think we are talking depending on the type of surgery, it's somewhere around 1,000 to $1,200 extra than any conventional laparoscopic surgery.
Okay. So
Somewhere around $1,200. Yeah, if I have to be very
this
precise.
this was the question by Dr. Onu from Nigeria.
Uh-huh.
Great advancement, but question is cost. Okay, so Dr. Onu, it is 1,000 to, depending on the surgery, 1,000 to $1,200. Dr. Deepika, now compared to resources, availability of resources and need of the patients. Yeah, ma'am, your
Uh-huh.
video was visible.
Yeah. Mm-hmm.
Yeah. So compared to the resources and the cost, and compared to the need for these surgeries, how do you determine that which patient is safe for open surgery, which patient laparoscope is good, and where robotic surgery should be preferred? So
Mm.
how is it?
They- Yeah. So see, few cases are pretty much straightforward. When we are doing laparoscopic or robotic surgery, for example, if it's a fibroid uterus we are talking. Now, if the fibroids are very massive, we are talking they are 4 5 centimeter above belly button, above the umbilicus, then we won't have any place space to put the camera in or to maneuver. Those are the very straightforward cases. I would tell them that it has to be an open surgery. But as long as any mass or any tumor which is well at the level of as big as at the level of belly button or above belly button, that is doable robotic surgeries. Now when we come to laparoscopic surgery, anything that is going somewhere around what we say is 18 to 20 week size uterus, it becomes tricky with laparoscopic surgery. So that's where the role of robotic comes, where you are pretty much confident that you can do them robotically. Secondly, cases like severe endometriosis, where there is lot of adhesions in severe endometriosis between the bowel and the uterus and the ovaries. Again, we want excellent precision, and precision is given by robot, which is 15 times more than laparoscope. So those are the cases where patients should definitely consider robotics. In multiple fibroids and endometriosis, they should. Like Afro-Caribbean women, they are very prone to fibroid uterus, and usually they have multiple fibroids as well. So I think they would benefit definitely more from robotic than laparoscopic surgery.
Okay. Uh, there is a question from Dr. Stephen Kope. He's from Cameroon. So first, he thanks you for this good presentation, and if he understood well,
Varun,
uh,
can you speak a little bit louder?
yeah. So another question and comment is from Dr. Stephen Kope. He's from Cameroon.
Mm-hmm.
And first, he thanks you for this good presentation. And his question is, with robotic surgery, there is no indication of hysterectomy in women with fibroids.
Well, it again depends on the age of the patient, her fertility desire as well. So sometimes we can offer hysterectomy also. Let's say if it's a perimenopausal woman around 48 years old, and she has completed her family and she has multiple fibroids, then yes, it's her choice whether she wants just the fibroids removed or would she like to have the uterus removed. Because sometimes women may have a very tiny little peanut size fibroids. Okay. Those are the ones we cannot take out at the time. We can take the ones which are more than 1 centimeter or 2 centimeters. So they can recur and they can regrow. So many a times it's always better in such women that they think about getting the uterus removed rather than saving the uterus. So these are the kind of discussions I would normally have with patient, and I would take them through the pros and cons of either. And then they can make a call.
Okay. Now, ma'am, one practical question, because open surgeries they are doing in Africa, even many countries, laparoscopic surgeries are also possible. So, how does a doctor, like a Jivo doctor partner, doctors who have attended this, how do they decide, given that the patient has financial resources, so how do they
Hmm.
decide that whether they should manage the case there or they should discuss referral with a specialist like you?
Well, I think so I understand your question is how should they decide whether they can manage the case in their own country or they should be referring, right? So,
Yes.
wherein the answer to that would be it depends on the expertise that they have around their area for that patient. And certainly if they have if there is a complex case with big fibroids or endometriosis, and the experts are not confident, or they feel that there may be a need to open them, then certainly those are the kind of patients they can refer to us, because we have technology here. We know with robot we can easily do them. And also with the laparoscopy, so they first need to gauge the expertise around their area, that how much the surgeons or the gynecologists are able to do it there, Varun. So it's difficult for me to tell that. However, I can speak about my expertise, and but I'm always there. They can always share, and the query it can be shared with me, and I'll be able to answer that.
Ma'am, that also, because we had in previous masterclass the topic of fibroid management was discussed, and there was
Uh-huh.
this thought around myectomy or hysterectomy, and
Mm-hmm.
one of the key factor was the age of the female and the desire whether they want to
Correct.
expand the family or not.
Mm-hmm.
Now, in that case, and especially you touched upon like the size of fibroids, etc. So,
Mm-hmm.
what I mean, again, I mean, you may have to sort of repeat what you said. So, in those
Mm-hmm.
cases, right? How are doctor partners evaluate? Like, depend on patient uniqueness. So, if somebody at what age they are and at what, so for whom is this robotics is sort of a boon at what?
Robotics is born for people who are high BMI. We are talking obese. BMI is more than 30, right? Because we want lesser anesthesia to those patients. Robotics is boon for people with definitely with severe endometriosis and multiple fibroids. Now, the reason I say multiple fibroids is because we are talking the multiple fibroids. Let's say if a woman has three fibroids ranging from 6 centimeter to 4 to 2 centimeter, that means scooping the three balls out. Fibroid is like a circular ball, and then reconstruction the uterus. And third part involve taking the fibroids by morcellating them, by shredding them. So it becomes a very lengthy surgery. We are talking 4 to 5 hours if I have to do it laparoscopically. With robot, perhaps couple of hours. So again, the risk of anesthesia is less, the blood loss is less, the stay is less. So these are the key patients where one should strongly think about robotic. And more so if it is a young woman who wants children in future, the integrity of uterus, which we get after suturing with a robot, is far better than laparoscopy surgery. So one
Uh,
should definitely think about it.
so, ma'am, if to simplify, let's say if it is a young female presenting with
Yes,
fibroids, so myectomy is suggested. So there, robotics makes sense because they have a fertile lifespan ahead, and
yes.
like minimal disturbance of uterus and better
Mm.
recovery. If somebody has a high BMI, so
Uh-huh.
risk of complication of anesthesia, and robotic has advantage over that. Okay.
Yes, high BMI, I would certainly advocate Varun. Definitely.
Okay. Okay. Now there's question from Dr. Robert Latio. Thanks for a precise presentation. You say clinical outcomes are highly dependent on the surgeon's experience. However, according to data, proficiency for complex cases like endometrial cancer may be reached in fewer than 10 cases with robotic systems compared to 40 for standard laparoscopy. What is your
Mm-hmm.
comment on this? And has there any cases you had to convert to open surgery in your practice so far?
So what was the first question? What is the?
She was that clinical outcomes are dependent on the surgeon's experience.
That's
But
correct. Huh?
according to some report, according to data, proficiency for complex cases like endometrial cancer may be reached in fewer than 10 cases with robotic systems compared to 40 for standard laparoscopy. So this is the first
Hmm.
question.
See, people who do training with the robotic surgery, most of them are anyway laparoscopic surgeon, right? So they have done a lot of laparoscopic surgeries in past. There are very few robotic surgeons who are de novo robotic, which means they never used to do any laparoscopic surgery. So clearly, if you have driven a car, which is a manual car, and now you're going to auto car, the proficiency will come sooner, isn't it? So if you have done many laparoscopic surgeries, endometrial cancer, and now it's robotic surgery, so I would expect proficiency to come after doing 10 cases, because you know what to do. You just need to know how to drive the robot. Does that answer his question or?
No, I think, ma'am, he asked the opposite. Uh,
Mm-hmm.
he says that according to some research and according to data, I mean, in robotic surgery, the proficiency is reached in fewer than 10 cases. White
Hmm.
laparoscopy, it's more than 40. So what he's arguing is that laparoscopy surgery has better outcomes than robotic systems.
Not that
Dr.
I am aware of, Varun, in that case. I mean, I have slides for some reason it's not working, which actually were showing that the outcome with the robotic surgery in terms of complications, readmission rates, blood loss, and post-op pain is less than laparoscopic surgeries. And those are the evidence-based data. I'll be happy to share those slides and you can share with them,
Sure, ma'am.
after the
We will
end.
share
Yeah,
it with the participants after the meeting.
sure,
Okay,
sure.
Robert Latio, I mean, if it is possible, can you ask the question direct because maybe we have misunderstood the question. Dr. Robert?
Yeah, sure.
Okay, his another question was, ma'am, have you encountered any case where you approached with robotic and it had to convert to open surgery in your particular?
Uh, I think I had one case in the last 3, 4 years, and I'm just trying to remember. Yes, I had one case in the last 4 years where I had to open her up purely because in robotic surgeries, patient are the head is at a 30-degree angle. It's really low down, and there was some issues with the lung compromise. The patient was not able to maintain the oxygen saturation. So initially we tried to undock the robot and have her head and up, and then we waited for 10 minutes and then we restarted it, but her saturations were going down, so we had to open her up. Yes. But
Okay.
that could be at time the limitations. But that's just one off. If you have a good team, anesthetist and all, usually that's get taken care of. We did have a good team, but yeah.
Okay. So, ma'am, typically this would be one out of how many? I mean, just so that doctor.
Varun, very, very rare does that. I mean, I can talk about myself. Ever in 3 years, this was the only case that I can recall. I think the most important thing is the patient selection. So, people who are beginning to do robotic surgeries, my, one suggestion to them would be that they should be very carefully selecting the patients. And gradually, as the number of cases you start doing, you'll be able to do more complex and more complex cases without the risk of opening up, isn't it? So we
Okay.
should be able to select our cases. We should know what we are doing it. Nevertheless, open surgery can happen. One can never say the chance is zero.
Okay. So, at a percent one, this would be less than 1% because in 3 years you
Yeah,
must
yeah.
have done multiple hundred surgeries,
Absolutely.
right? Okay. And
Absolutely.
out of multiple
Absolutely.
hundred,
Maybe one in 100 case we can say. One, yeah.
okay. So another question from Dr. EPA. He's from Kinshasa, DRC. So he thanks
Okay.
you for the presentation, and just out of curiosity, he just wants to know like how many cases like robotic surgeries you have. So basically, his question is how many robotic surgeries have you done in your career, and what was the success? How many were successful, if you include post-operative recovery stage? I mean,
Well, with
a little
God's
different.
grace, none of my patient, ended up in ICU or things like that. So they have all recovered beautifully with God's grace. I have done almost more than 400, 500 robotic surgeries so far.
Okay.
Yeah.
So out of 400, 500, ma'am, at the post-operative stage, so no complications and almost 100% success rate.
Yes, I cannot recall any complications in terms of any injury to the bladder, bowel, ureter, stuff like that. Yes.
Okay. So there is a question from Dr. Orunana Paul. He's from Nigeria. So he wants to talk about the success rate. So are robotic surgery success rates better than the traditional surgery, open surgery?
There is absolutely no thought about it, no second thought about it. Um, because the tissue or the organs, whether it like let's talk about the ureter or the lymph nodes, the magnification is so good that the complication rate is less than in open surgery. And when we are doing traditional open surgeries, we are losing more blood in those patients. We are giving a big cut that is increasing to the morbidity of the patients, right? So and this is my journey as a surgeon. I used to do a lot of open surgeries before 2000. Then I entered into laparoscopy and now into robotics, so I can definitely make the comparison, you know yeah. But whenever open is needed, it is needed in certain cases of ovarian cancers or, as I said, very large fibroid uterus.
Okay. So, ma'am, now we have a question from Professor Daniel Okitundu. He is from Kinshasa, DRC. He
Okay.
is director and HOD of neurology department there, and his
Mm-hmm.
specialty is psychopathology in neurology. So, which is
Okay.
I mean, one of the few specialists. So, his question is, what is the failure rate in robotic surgery?
See, I want to know, when they say failure rate, what do they mean by that? Failure rate could be opening to an open surgery, or does he mean complication, or does he mean not being able to do it at all? So, what is the definition?
Okay. Ma'am, just for clarity, because the question could be vague, if we take these three parameters, like chances of open surgery, you answered one in one
One in
case,
100, let's say.
and then second is complication, and third is like not viable, robotic surgery not viable. If you can
Mhm.
explain, this is more for understanding, ma'am.
Okay. So let's start with robotic surgery not viable. Well, if you are an expert in robotic surgery, one should be able to make that decision pre-operatively, not after putting the robot in, oh, okay, I can't do it. Because that's more about the pre-operative planning, which means getting the requisite tests done. If you're not satisfied with the ultrasound report, I would get an MRI done or a CT done, so that is very crucial. Second thing is the complications, the risk of complications. Yes, injury can happen in robotic surgery, and the risk is less than 1% again with robotic surgery. Again, it depends on the what kind of injury. For example, with laparoscopy, we talk about bladder, bowel, and ureter. As a gynecologist, these are the, and vessel injury. These are the four main injuries that we are talking. And if I talk about the bowel injury and the vessel injury, the risk is less than 0.5%, and and same with the bladder injury. And with laparoscopic surgery, we are talking around 1 to 2%.
Okay. So ma'am, in a nutshell, like compared to while like laparoscopic surgery is also very precise, robotic makes it
Mhm.
even more precise, right? So
That's
that 1
true.
to 2% gets reduced to 0.5%.
0.5, very, very less. Yeah.
Now, we have a question from Dr. Again, a follow-up question from Dr. Orunana Paul. So, how do we clearly distinguish laparoscopic surgery from robotic surgery?
So, which means where we would definitely prefer robotic surgery to laparoscopic surgery. Am I right to interpret this question?
I think we have to interpret it this way. Or Dr.
Yeah.
Orunana Paul, you can clarify
Or
whether
you
I...
can check with, yeah.
Let's go with this interpretation, ma'am.
Okay, so the if I have to talk about the clear indication for robotic surgery, number one is severe endometriosis, number two is multiple fibroid uterus, number three is high BMI, obese women. These are the three kind of cases who must think about robotic surgeries.
Okay. So, ma'am, I have in this discussion we while we discuss case use of robotic surgery, but we kept it to major problems like fibroids, endometriosis. So,
Mm-hmm.
in case of cancer, where oncology, surgical oncology, like it becomes a multidisciplinary case. So, how do
Yes.
you approach it? Is
How do
robotic
I approach it?
is robotic surgery still relevant there?
Yes, so robotic surgery has a huge role in cancer surgeries and traditionally also. So the introduction of robot was more in gynae was to start with the gynae oncology, right? And the reason behind that is because cancer surgeries are very long surgeries and they are integrate surgeries. You have to do a lot of dissections around the ureter area because there is lymph node removal. Then the lymph nodes are around the parietic vessels and there are vessels in the pelvic areas also. And then there are many nerves which are going around that area and blood vessels also. So that's how the role of robotics is in onc. And whenever I am doing any gynae oncology surgery, because I'm not a gynae onc robotic surgeon, I would do my area, which is the removal of the uterus, tubes, and ovaries and all, and then the lymph nodes and all are taken by the gynae onc team.
Okay. So, I think, ma'am, we have had a lot of questions. I don't see any further question. So,
Okay.
there's a lot
I'm
of
so
doctors.
sorry for some reason the video was not getting started. I don't know, but yeah, I
No, no
hope
problem.
I was
Uh,
audible.
So, there were a few questions from French speakers. So, I will draft their answer in
Sure.
French language and share it on your groups. If you have any more questions around robotic surgery and its application in gynecology. Although, ma'am, I broke the rule. The question was your topic was benign gynecology, but
No,
I still
that's all
included the
right.
cancer aspect in it.
Hmm.
So, but however, since we're discussing it, I thought it could if we could just briefly discuss about it. And if we have no further question, ma'am, if we can conclude the session. Uh,
Sure. So yeah. So, first of all, I again want to thank everyone for being there, and I'll be there. If you have any queries, any questions, or if you're not sure about any patients, Varun, you can share my number as well with them. I'll be very happy to be connected directly also, or they can come through you. So, or if they still have anything that comes to your all mind after we conclude the session today, please feel free to send to Varun, and I'll be happy to answer those questions.
Dr. Deepika, we have working groups with all the doctor partners, and we have
Mhm.
assigned a relationship manager to everybody.
Sure.
So sometimes in French cases, a French-speaking person. So if you have any questions, any follow-up questions around robotic surgery or its application in gynecology, or any question for Dr. Deepika, please feel free to share on your work group. Your relationship manager will pick it up and the question will be directed to Dr. Deepika through Artemis team. And the turnaround time, response time with Artemis is very short, and we'll get you the response in the shortest possible time.
Yeah. And I'll be looking for a very fruitful collaboration with you all.
Yeah. Thank you, Dr.
Thank you.
Deepika, for taking time out on a Sunday where you
Thank
had
you.
already
Thanks
had
to
some
all of
surgery
you.
planned. And thank you, everyone, our doctor partners from Pan Africa who took time out on a Sunday and joined this meeting. Thanks a lot.
Thank you. Thank you. Thank you. Good evening, Varun.
Ma'am,
Thank
there
you.
is one more question. Sorry.
Am I still there?
Yeah, you're still there.
हाँ
So,
जी बताइए.
Dr. Desio Bezabi from Ethiopia. His question
Okay.
is, what is your plan to expand those clinical activities in developing countries? That is a place for making gynecologists expert in robotic or laparoscopy in developing countries, say for example like Ethiopia. So are there any plans, ma'am, at level of Artemis Hospital of training
I think
those
Artemis
level?
has been very proactive. So it has been very, very proactive with all sorts of expansions, and they are very much into the international world. And obviously, we are there to support it. Now, with the new digital world, like the Zoom meeting we have had today, these things can happen. And also, I'll be very happy to be a part of if any travel needs to be placed, we can always take out time once in couple of months and be there and be with the doctors there and be with the patients also. So, and if
So,
anybody has any further suggestions, that's more welcome. So we
so I
can
have
all.
I have a relevant question, ma'am.
Yes, tell
So
me,
I'm
Varun.
aware that Artemis was working towards building these training fellowships, etc. So
Mm-hmm.
that where doctors, surgeons from other countries can come and spend few months there, train with a doctor. When is that going to be launched? When
Well,
is that?
that's a good thing. I'll probably put it forward through because yes, we like we do have our Indian fellows and consultants with us who come, who watch, who learn, and yeah, I'll probably take it forward, Varun. Why not? I'll be very happy. I'm a very proactive person when it comes to teaching and training because the skills that we have acquired, it's good that we can spread around and more people can, gain the expertise in this.
Okay. Ma'am, the one thing that we can do is that some of the doctor partners, they are like directors and deans at universities. If we can do some training session, which is possible online, so that more students.
Mm-hmm.
So
Mm.
I can discuss that with you later
Sure.
on.
Sure, Varun.
Thank
Definitely.
you, ma'am. Thank you,
Definitely.
ma'am. Thank you.
Thank
Thanks.
you. Have a very good evening.